Unfortunately, my voice is not the best today, but I'll try by all means to make it clear for people to follow my presentation. So this is a presentation where we are looking at, we had an index case, and our task was how can we do a comprehensive contact tracing? And this is in one of the districts within Zambia, where we had a rifampicin resistant case. So we know that the contacts to those with TB are at a higher risk of having TB, and we know that the prevalence among the DRI or extensive DRI is around 3.4%, and we know that the risk of having or developing the TB disease, it's higher in the first and the second year after the infection. So this is the time we want to follow all the patients, all the contacts, to check if there's anyone who may have developed the disease. So through our project, we had this we had one of our patient. She was 23 years old, and this was a retreatment, and we found that the results came out rifampicin resistance. And one other thing which we noted was that this same patient at one point or another did not take the drugs the way she was supposed to take, putting the family members at risk of developing TB. So at the time of diagnosis, she had been in the pediatric ward for about 3 months, attending to her 13-month-old baby who was admitted with acute malnutrition. So we were all concerned looking at the child who was malnourished, and in that she also came out rifampicin resistant. So what the team had to do was to elicit all the close contacts, and what we did was we even went into the ward where she was admitted, just to make sure that all the health workers who were attending to her are also screened for TB, then the household, and we went up to the house of this individual. And the interesting part was she was staying in one house. There were 18, and that house had only 4 rooms, and this includes the living room, 2 bedrooms, and the kitchen. So it means at the end of the day, all the 18, they have to spend the night in that room. Then we also found that the other side, she was the mother to the index case. She was also staying somewhere else, where she was staying in a 1 room, and there were 6 family members. So you see, there are a lot of things which go on, especially in these high density places. So all contacts were screened for TB, and it became more interesting, especially that when some of them came out positive. So we had to engage people even from our national hospital just to come and help screen. So all the contacts were screened for TB using both using the gene expert or the expert MTB-RIF, and also to make sure that their samples were sent for culture. And apart from just doing symptomatic screening, we also made sure that everyone had access to a chest X-ray. And what we found was so interesting, in that looking at the 2 homes where there were 18 and also where there were 16, that is 24, we were able to diagnose 12. And these are decisions which we had to make, because apart from just doing the sputum examination, you see as we go, some of them were clinically diagnosed, which is about 9 of them were clinically diagnosed. And we had to bring in specialists to look at the chest X-rays to make sure that we are making the right decision. And it was interesting that some of them already, even the time we were finding with TB, they were already having signs and symptoms And some of them, we tried to put them on first-line treatment, especially where they came out MTB detected, but RR not detected. So we tried to put them on first-line drugs, but we were not seeing an improvement until later on when they were changed to second-line treatment. So we saw all of them improving. And I should mention that among those who were clinically diagnosed, it included a child who was 13 years old. Then there was another one who was 13 months and also 7 months. Unfortunately, the 13 months old baby, after just some weeks, we lost that one, and she's the one who was actually admitted in the ward and being managed there. So that's just trying to show, to say, yes, we had this patient who was staying with 18 family members there. That is at the auntie's place. Well, the other side where there were 6, that is the mother. And this is a patient who was visiting these, she was staying at the auntie's place, but she could visit the mother. And we did the screening for both families. And when you look at the first arm where we are looking at 8 family members, we managed to find 11 of them having TB, and out of those, 2 had the gene expert or the expert MTB results came out positive, though they were not rifampicin resistant, and those are the ones we at first tried to put them on drug susceptible TB, and we could not see improvement, so we ended up switching them to second-line treatment. And we had all those the 9 clinically diagnosed, which included the children. Then to the mother's place, when we screened, when we collected the sputum from that family, we managed to find 1 case of TB, and that was a mother to the index case. And for her, even the results came out MTB detected, RR detected, which means she also had drug-resistant TB. So there are a lot of lessons we can get from there, and it has been very interesting. Actually, we didn't even end there. There is also one other thing which I didn't include here. After some months of follow-up, we found that actually even the boyfriend to the same patient also had drug-resistant TB, and this is another person who once in a while was even assisting in our health facilities, providing a service. So those are some of the things, and the lessons we are learning from there is that we need to have a well-structured contact tracing, especially if you have a patient who you see adherence not very good. We can do a well-structured contact tracing where we can also use a chest X-ray and combine with sputum examination. That way, I think it can be very helpful in detecting the TB patients. So those are some of the things we need to do if we are to improve on the number of cases. I would just like to thank the team from CIDAS for the Center for Infectious Disease Research in Zambia, and also the Ministry of Health, and also the team at Mazabuka General Hospital for their support. And thank you very much.